screen, but in respect for everyone's time, we're going to go ahead and begin. And just so everyone knows, ACME is putting on this webinar, and this just says that, the information presented is not medical advice. Please mute except for all lines except for the presenters. Submit your questions in the chat window. Those that are requesting certificate, follow the information. I'll put it back at the end. And COPA Education will be sending the certificates. In addition, here is the ACME Board of Directors. I won't read to you guys since you can all read. And next, I'd like to introduce Dr. Michael Franczak. Dr. Franczak has served as the director, he serves right now as the director of population health for COPA Health, Mesa, Arizona. Dr. Franczak has been involved in mental health, substance abuse, developmental disabilities services in not only Arizona, Pennsylvania, North Carolina for 40 years. He serves as an expert witness in many landmark cases concerning mental health, developmental disabilities, and serves as an expert to the U.S. Department of Justice Civil Rights Division. So I know he visits a lot of states, visits their facilities, and provides wisdom and counsel. So with that, Mike, I'll turn it over to you, and just tell me next when you want your next slides.
Okay, you can go to the next slide. I have a disclaimer, is that the information that we're going to talk about today is not specifically COPA related or Maricopa or Arizona related. It's based on my experiences and the many roles I've played in the field. And I've had, with the Department of Justice Civil Rights Division, had an opportunity to go to at least 15 states and another 10 based on other cases. So again, this data is going to be based on my overall experiences, which have been confirmed again and again. And so today I'm Director of Population Health, which is a title that came out a couple of years ago as a field. But, and I'm glad they finally, I think I've been doing it all my career.
Oh, listen.
But I believe that it's been, finally someone gave a name to it. So population health is the study of the entire population that we're targeting to serve, the outcomes that we're getting, the people who have risks that are not being met, how we get clinical teams to intervene, and how we begin to bring providers together to do more successful interventions. So we're looking at a combination of care management, clinical outcomes, analysis of the population, quality management of the services, patient engagement, and of course, we have to look at revenue management. So moving to the next slide.
Well, one thing, Mike, that's good that you said, because we have people from other areas, and it's nice to know that this information or this concept is applicable, right?
Yeah. Well, I think it is. I think it's very important, and more agencies are using this approach. So the big issue is there's big data out there. We got data on all kinds of things. People coming into services, people going into hospitals, emergency rooms, people not connecting, not showing for appointments, people not adhering or taking medications that they're prescribed. But the really important part is we got to use the data to focus our interventions. So we got to sift through data to make sure it's actionable. I always tell people, with all the data sources that I'm looking at, you don't want to see how we make the sausage, because it's a really complex collection of data that you have to combine and then identify what's useful, So I think Einstein said somewhere that, everything that's countable it does not count. So, and things that are not countable count more. So He was very correct in that observation. So anyway, we start by by looking at the high utilization of services for folks, people who go to the ED or inpatient settings very often. I've had people, and this was in another state, that the person went in the hospital 95 times a year, right? Those kinds of things suggest or, give us a lead into, well, something's not working in their community living setting that they have to go to the hospital that often. We look at high cost. We look at high need, people who have multiple chronic conditions, which we're going to talk about. We look at people who have gaps in care, people who are not getting your routine preventative screenings. We look at a lot of social determinant factors, and I'm going to talk more about that later. But our main job is to improve the outcomes, both physical and behavioral health outcomes, using care management and targeting teams to issues that seem to require additional attention by staff. Next slide. So again, we use social determinants. Comorbidities is an issue we look at constantly. And in that case, we see people with a serious mental illness that often have 4, 5, or 6 chronic medical conditions as well. Now, we'll talk more about the interplay between physical health and behavioral health later, but what I've found is many people with comorbidities are not addressing those comorbidities, and some of them have not seen their PCP in years. And yet, they're been diagnosed with chronic conditions like diabetes or hypertension or COPD or others, and they're not being addressed. Okay, and then what we do is known as risk stratification. This is a process by which we look at all of these things like utilization, comorbidities, and whatever, and then we determine the person's risk. Now, originally we were using a program called LightBeam, which uses a risk stratification system developed by Johns Hopkins. Now, the Johns Hopkins model was really heavily based purely on medical conditions and did not account for the additional effect of mental health conditions. So that model, while wonderful, it was not working. The other thing about risk is I've discovered that there's several kinds of risk. One kind of risk is the general risk of having all of these things going on. Your health is going to go downhill faster and you're going to, expire quicker. So that's long-term risk. I also look at immediate risk, and that is who is popping on, utilizing a lot of things right now. And it's almost like the automobile model of risk stratification or the automobile insurance model, which is automobile companies charge a hell of a lot more money for young drivers and old drivers. That's for probability. But the people they charge the most for are people who have repeat accidents. So in some ways, there's two kinds of risk. And Lori, as an engineer, someday you can help educate me about risk analysis. But then I boil down a lot of these numbers so I can get risk numbers to action. I then do what I call a functional risk analysis, which we will talk about before, and then I build the team in and we do skillful adaptations. So next slide. So where do I get all this data? I get it from a big piece of it from Health Current, which is our HIE in Arizona. And I get what's known as admission discharge notices. And then I also get batch alerts from them about everyone going into the hospitals and or emergency rooms, provided that they're connected to the HIE. And today, more and more hospitals are. Then I get it from our our electronic medical record, which we have, most of our clinics are primary care, so I can abstract information from progress notes, assessments, interventions, etc. Then at each location, and Mercy Care has a discharge, well, they're care managers at every one of the hospitals, but they don't have them in emergency rooms and they don't have them in the urgent care centers. At any time when I'm speaking in Blythe, Dr. Fitzharris has a way to correct me. Please do, so I learn from my mistakes. So then we have data from our MCO, our managed care organization, the care managers who alert us. And I get probably 20 alerts a day from them saying, you know, Chuck just went into Banner. We need to, you know, connect with you to develop a discharge plan. Then I get claims files that we get over time. The problem with that is that's all old. It takes about 6 months for a claim to go from a person delivering care to it going through the managed care organization and then up to the access, which is our health plan in Arizona. So it's old data. So the problem there would be like it's you're driving your car only looking through the rear view mirror. So I can't correct the past. So we got to use as much current data, real-time data as possible. And so we're also involved in the Access TIP program, which incentivizes us to, you know, perform certain outcomes or collect certain outcomes. And all of that data is brought together in this stew that we need to boil down. It's sort of like a French reduction sauce, so to speak. Anyway, moving to the next. I worked in a French restaurant once when I was in college. It takes about a week to make a French reduction sauce.
Yeah.
You've got to boil down the bones so that even a dog wouldn't take them. Because what you want is the essence of the marrow. So anyway, that's enough on cooking. This is not a cooking show.
So Mike, 2 questions. One, do you know or do you feel that most providers have this level of data analysis and population health, or do you think that COPA is unique in having this type of analysis and big data?
Well, we put a lot of work into it. I believe all of the providers are doing something. I think that we've, you know, I don't know exactly whether every provider has it, and small providers may not have the manpower to do all this. But a lot of this is portable and scalable. So again, Dr. Fitzharris, do you think all providers are doing this? Dr. Fitzharris refuses to answer on the grounds that they incriminate.
Blythe, if you want to jump in, just unmute. Okay, while she's, if she's looking at, one other thing, is there a, it seems like there may be an opportunity, especially for familiar faces, to provide that information sooner than the 6th month. If you have people that are more active in the system, you would think that maybe you could identify some and ask for quicker information.
Yeah, well, we get back to the quickest information we get is from the HIE ADT alerts and from the care managers. Because we're contacted every time someone hits a hospital. We are not necessarily contacted when someone hits emergency rooms.
Okay.
But anyway, I think that, you know, I can't speak for other programs. I know everybody's trying to get at this, but almost we can identify that 2 or 3% of our population are the people that are highly utilizing services. And what we've got to do is separate those who need those services frequently from those people who are using it because of social determinants and other reasons. And that's what part of this job is. We got to look for a term that's called ability to impact, right? There are a number of people who are using those services, expensive services, that are going to continue to use those and need to continue to use those. And we're not taking away services from people who need them. So we need to identify those and identify we don't have an ability to change this by doing something different out here. Hospitals are there and emergency rooms are there for a purpose and they serve it well. So moving to the next slide.
Okay, Blythe answered that she thinks providers have at least some of this level of population health via the HIE or other data on utilization.
Thank you, Blythe. So what I try to do is identify and decode risk factors. So one of the things that we see is if someone's going into the emergency room frequently with a particular medical complaint, emergency rooms try to do their best. And emergency rooms, and I'd like Chuck to chip in here, emergency rooms can be expensive. And emergency rooms get really expensive when you have to constantly retest somebody. And we have a number of people who, one of the first things I say is, what emergency room are they going to? It's because we can contact there and talk to them sometimes. Some of the times, though, they're using different emergency rooms and they're all over the place. And one emergency room doesn't necessarily know what another emergency room did. But if we see somebody's going in there constantly with a stomach complaint, we need to connect them, with the right specialist about what is wrong here, because we got to get to the bottom of it. So Chuck, I think you've seen that in your experience in emergency rooms, that a lot of people are coming in with, complaints that normally wouldn't require emergency room usage.
It's hard to actually say that because every from the point of view of an emergency physician, when somebody comes in, we have to evaluate them very thoroughly. We have in our minds their best interests as patients. We also have in mind our own best interests, because we don't want to run afoul of many different things that we have to pay attention to with respect to regulations, with respect to actually being a doctor, and making sure that we're not making sure that we're responding to the responsibilities of being a physician. So what this all boils down to is that what Mike is alluding to here, and which hopefully I can make more clear, is there is a certain coterie of patients that come to the hospital repeatedly. And it's very difficult to actually quantify why they come, because ones that come, which of course in the emergency parlance we call frequent flyers, don't necessarily have anything that we in the emergency room can do for them. So they come with very abstract complaints that are difficult to deal with, not really emergency department material, vague abdominal pain, headaches, not feeling well. These are very often the complaints of people that are frequent flyers. The problem is that every once in a while, one of these complaints turns out to be something that is material in terms of what we do in the emergency department, something we could actually do something about. So, for example, a headache could be something that is a bleeding aneurysm. A complaint for the 30th time in a row of abdominal pain can actually be acute appendicitis, or an aneurysm in the abdomen that needs actually needs emergency department evaluation and treatment. So we have to treat all these patients, no matter how often they come in, with the same degree of evidence and evaluation that we would any other one. And the problem is that some of these people come in with, say, for example, a very abstract complaint of abdominal pain, and they come in very often for that. And I can tell you as an emergency doctor, in order to evaluate a person who's anywhere from 40 or 50 years old with abdominal pain requires a lot of resources, and that a lot of resources translates into a lot of cost. So for somebody who comes in, and as I have had in my own history, anywhere between 90 and 200 times a year for a complaint of abdominal pain and gets a workup that costs somewhere between $2,000 and $5,000, this is a real problem. And this is the problem that Mike is alluding to.
Yeah, so one of the things I think I found with the people that I found had high emergency room usage is that they don't have a health home other than the ER. The ER, you are their only health care connection, and they've never connected with any PCP in the community. And they often, even if you tell them at an emergency room to please follow up with this specialist, the likelihood they will do that is pretty small unless there's enough support. So going on with this, I see the opioid deception. We've seen, and there's been a decrease in that, some of the things we put in place to identify people who we call doctor shopping, who are continuing to go to sometimes 10 or 15 doctors to get the same prescription. I think we've put a serious dent in that with some of the things we've implemented. We've got location and proximity issues. We have people that live near an emergency room, use emergency rooms more than they use anything else. I already said that you become their health home. Health literacy is our ability to understand our health, our conditions, and what we need to do about it. We have, with folks we're serving, we have, the research is pretty clear that there's really low health literacy about what this condition means, what I should and shouldn't do, what I should and shouldn't eat or drink. But we need to train more folks to understand health literacy. And then we have our social determinants of health, our housing, food insecurity, social isolation, family relationships and stressors, finances. You know, one of the things I learned here about this particular issue is that you probably all heard about Maslow's hierarchy. Everybody heard about it in their career one way or another. And Maslow came up with a hierarchy. And by the way, I understand that he learned some of this from the Blackfeet Indians in Montana, which is odd. But anyway, so there's a hierarchy where people in the bottom layer of our hierarchy, it's our safety needs, you know, security, food, shelter, whatever. And then as you move up the hierarchy, you have your social needs, and then you even have, self-expression and whatever. And most of us here on the phone or on the Zoom are pretty high up on Maslow's hierarchy. So when we look down at someone else on the hierarchy who's in the safety phase of their life, we think, why, that's irrational. Nobody would go to an emergency room 45 times a year, or nobody would try to get psychiatrically hospitalized, But we're looking at it from a different level. When we look at it from the person's level in the hierarchy, it's perfectly rational. Almost every one of us, if we were starving, if we had no place to live, if we had all of our clothes were dirty, we had no bed to sleep on, we would start using emergency rooms. Chuck, you'd have to build a lot more of them. So it's a matter of like putting yourself in the person's shoes to decide on what the decision making process is. I've learned that rationality is relative, that in that person's shoes, all of us would do about the same thing. And that's where you've got to operate from, that level. So moving on. So we developed this high risk registry. We established clinical teams that we can focus. Now, right now, I don't know, Blythe, correct me if I'm wrong, but there's somewhere close to 25,000 people in the system of individuals with serious mental illness in Maricopa County. Maybe not quite that high, but close.
Yeah, no, you're right on there, Dr. Franczak.
Yeah, okay, so we have clinical teams that serve these individuals. The clinical team, there's 3 levels of case management: assertive, supportive, and connective. A clinical team of supportive, where most people are, serves 30 people. So you get a case manager that serves 30 people. Their days are just filled with putting out the crises, getting things done for people. What I find that we need to do is get them to focus on people that are having the biggest problems instead of just what's up next at the desk. And they have a lot of time spent doing paperwork. So we do what I call a functional risk analysis, which is looking into, okay, what's going on? And we use the model. Lori, you're probably familiar with the Toyota 5Y model.
Yes.
That they use in quality assurance. So what we do is try to get down to the bottom of what's going on here. Why is this happening for you? What are you not getting? And what we do is we take the fact that people have made a choice. Now, from our high level on Maslow, we may think it's an irrational choice, but they're making choices just like we all do. There's a term for this choice making that is used by Amazon and almost everybody that we shop with, where it's called digital dust. And digital dust is every time we make a choice, we leave something behind. So that's why if you order a book on Amazon on, a female detective novel, you're going to get, hey, we should suggest these other female detective novel books for you, because Amazon, you left dust in the system. So when I look at choices people make, regardless of whether I think it's rational or not, they've left dust. They've told us what they did and why, then we know, like, okay, why did you make that choice? And so it comes down to, doing some sort of analysis. So the goal that we really have is to provide effective treatment in the community as an alternative to high cost settings. When high cost settings are necessary, they are to be used for sure. That's why we have the excellent medical care that we have in the state of, or in the USA. So next slide, please. So one of the things that we know is that this is the expenditure of, and I'm not sure if it's medical expenditure entirely, including Medicaid, Medicare, and private insurance. I don't know if you know this, but 5% of the population uses approximately 50% of all the medical resources and the most expense. 10% use 65% of the resources. And 50% of the people use less than 3% of the resources. Now, that is not necessarily to say that everybody who's not using resources is healthy. But for the most part, they're able to manage their own health care so that they're living okay, right? So anyone have any comments on that? I'd like to have more of a discussion than just a lecture.
Okay, we did have a question earlier about from Ralph for a comment. Don't ERs attenuate the level of investigation as a frequent flyer progresses in time? From what I've learned from my husband, he said that you really, because of our litigation nature in the US and the standard of care, if someone says they have a stomach ache today, they still run the same amount of tests.
Yeah. Yeah, that's my understanding now. What we try to do with frequent ER users is to say, what is your issue that you're trying to get resolved at ER? It's going to be a temporary thing. Let's get you some resolution to your stomach issue through your PCP. And sometimes it's simply, you need to buy Pepcid. If you got heartburn, there are other things on the counter that you can use to reduce the heartburn. Or here's another one I've seen. I've got my heart palpitations. They go to the ER and they say there's nothing wrong with your heart. And what's actually happening is they're having anxiety attacks, which are not being treated. So, I mean, you've got to be creative in solving that. By the way, in our world, frequent flyers are called familiar faces. We have to always be politically correct.
I like that.
So anyway, the next slide. And then more and more of the research is showing that 10% of our health, most of our wellness, physical health and mental health wellness, 10% of it is related to what we do healthcare wise. Some percent is due to the environmental exposure to conditions in which we live. There's a genetic load of 30%. There's social circumstances, homelessness, lack of access to care, joblessness, etc. And then another 40% is due to behavior patterns, low levels of literacy, substance abuse, depression, other things. So if you're expecting to get yourself healthy by seeing your physician as the only thing you're doing about your own health, and that the second you leave there, you go back to exactly what you're doing, regardless of what the physician is recommending, you're not going to get a lot better. The physician is giving you advice, giving you information, giving you assistance to treat problems. But unless you're doing something about it outside the 23 3/4 hours that you're not with them, you're not going to get as healthy as possible. So moving on to the next slide.
Well, Mike, you read the book for the Columbia meeting, The Rabbit Effect.
Yes, The Rabbit Effect.
Very, very interesting book, recommend it, where they were showing that rat mothers that lick their babies have healthier babies. Even if they're not their babies, they can lick other ones and they do well. And some remarkable research on just the environment.
Oh, it's an excellent book. I recommend it to everyone. So with respect to social determinants, and by the way, I think I see Christy Dye on the phone now, on the Zoom. Health Current is implementing with Access, and I think the Crisis Response Center, a model that we're able to use to connect people with resources for their social determinant needs in the in the short future. They're working on it intensely. So many of these supports, and Christy, you might want to chip in here. Many of the supports that are related to social determinant needs are outside the scope of Medicare, Medicaid, or commercial health plans. They're not gonna, when was the last time you went to the PCP and he said, oh, your housing is a problem. Let me help me fix your housing, or or even the simple things like, let's get you a food box, or how's your transportation to get to a supermarket? That's not their scope. So more and more, they are becoming health homes and addressing that. Many healthcare organizations are trying to find and build relationships with community providers. Christy, do you want to talk about that at all? I don't know, you're on mute.
I
Anyway,
am on mute. Sorry about that. I don't know, at a high level, I don't know much more that I would add, Mike, other than we're implementing a system that allows providers to connect directly to community-based organizations to fill social needs and have a established pathway for making the referral and then getting a return response from the community-based organization, so you actually know the person made it to the referral appointment for whatever those social risks are, like food boxes, housing application appointments, those kinds of things.
clothing,
Clothing,
shelter. So anyway,
Shelter.
that's going to be a great improvement. But most community support organizations are nonprofit, charitable, or religious. They don't have a big staff. They don't have a big budget. They don't have a large IT system. So they're currently challenged. But many of behavioral health providers with case managers have been doing that all along, but PCPs have not had that opportunity. But the good news is what I said is Health Current and Access are trying to address that.
And we just had a message from David Bridge from Access that the closed loop referral system with Health Current, that's a good thing. On another note, do we know if there's a national trend for Medicaid or payers to start looking at these social determinants of health, saying, you know, if they're living under a bridge, they're not going to get better if they're not eating a meal. So do we think that housing and maybe food would become part of a payable service?
I know at the national level, CMS has been talking about it. I'm not sure they've been able to get the funding necessary. I think David might know more about that from the Access level. David?
You want to pop in? You can, David.
Oh, thank you. Access specifically has an initiative right now called the Whole Person Care Initiative that we've been working on to look specifically at a lot of the things you're talking about, including integrating housing strategies, transportation strategies, closed loop referrals, try to connect people to community services. I can try to send the link to you, but there was a memo that was put out by CMS, I think at the end of January, that encouraged, that acknowledged that social determinants of health are an important part of an overall healthcare program, and encouraged, again, they didn't give any specific guidance, but they did encourage community or state Medicaid programs to look at ways to maybe use waiver authority or some of their other capabilities to see if they could support certain types of social determinant work. There is no state that has allowed Medicaid dollars to reimburse for rent, but there are some cases where they may have used Medicaid dollars have been requested to maybe support other types of eviction prevention, other types of wraparound services related to housing. Most of my knowledge is about housing. I don't know the other stuff, but there is a trend in CMS, and they have been promoting this idea of social determinants.
Yeah, at the end of this presentation, I have a slide that shows the whole health initiative that you guys have put together. So we'll get to that one. So moving on, there's a big interplay between behavioral health and physical health illnesses. Although, it's not clear, it's not a chicken or egg issue. There is some sort of bidirectional influence. People who have severe and enduring mental health problems, such as depression, dementia, psychosis, are at high risk for developing also physical health issues, mainly because they're not attending to it. And individuals with physical health issues, as they mount up, also have a tendency to have more behavioral health issues. So moving on. So some of the data shows that a quarter of Americans meet the criteria for mental illness at some point in their life. And a lot of the population, essentially 34 million, have both physical health and mental health issues. So that's just basically saying the same thing. There's a lot of comorbidity across both physical and mental health. Moving on. This is particularly people with mental illness have, increased risk of hypertension, asthma, diabetes, heart disease, and stroke. And unfortunately, some of the psychiatric medications that are given today cause weight gain, which is kind of cascades into obesity and type 2 diabetes. And prescribers need to be careful that they're monitoring those conditions. One of the things Access has done in their TIP program is reminded us that we have to be preventative and measure A1C values, particularly for those people who are getting those medications, and to intervene early on. Moving on. Okay, so I wanted to tell you a little bit more about the psychiatric or functional analysis process. It begins by looking at the social supports, and you're probably not going to be able to read this particularly, but what it is a process I put in place that we are using. And first of all, one of the things we do right away is look at the social determinants and the social supports of individuals. I found that if we begin by asking housing and talk about stability, and it's not just homelessness, it's that people are living in conditions and with people who are not, supporting them. Stable food, stable transportation, whatever. So once we identify you're living okay, we move on to other factors. But however, I've got to tell you that I looked at some recent data that shows that somewhere close to 40% of the people that we see are high utilizers have housing instability in one form or another, either homelessness or couch surfing or living with an abusive spouse or living in a family with their parents that don't really, they're not getting along. And that is a really big factor in a lot of this utilization. Then we look at biological conditions, acute chronic medical conditions. Are they attending to those conditions? Are they connected with their PCP? The emergency room utilization, and then their health literacy. If they even went to their PCP, would they follow anything the PCP says? And for that is another big issue. Then we go for, one of the things that we do find is that the follow-up with specialists does not occur at the level it has to without much support. Then I look at psychiatric stability. They're coming to their appointments. They're going to other things that are related to their interventions, perhaps counseling, perhaps they're, looking for a job. So is there psychiatric stability where it needs to be? And in that case, we found a number of individuals who are not taking their medications. They couldn't be taking their medications because they haven't shown up for 6 months. So I did talk to pharmacies and tried to find out, okay, if a physician writes a prescription and it isn't picked up, what do you do with it? And they say, well, you restock it. And I said, okay, do you ever let the physician know that the prescription he wrote was never picked up? And they said, no, we don't do that. So one of the things I think we need to work on is bidirectional work with the pharmacy. Now, if the physician knew that the prescription they prescribed was not picked up, pretty much they're going to ask, like, the question is, like, why? In Medicaid, it's not a problem. The expense isn't a problem. Is it that medication produces side effects that I don't like? Is it, whatever, I can't get to the pharmacy? Or what is the reason you don't take it? Because sometimes the physician people do fib. So when they go into their physician and they say, how's the medication working? They say, oh, great. Or, oh, it's not doing well. Or the physician can see they're not doing well. They say, well, I better up the dose on that. And that doesn't get picked up. So we're in a kind of a vicious circle without a bidirectional feedback. Then we come up with a hypothesis. Okay, what is the why? Why is this going on? And then we come up with an intervention, with the intervention targeted to replace the reason for making those decisions. So there are two ways to do it. We make the response unnecessary because we look at the problem and fix it in another way, so that if I got a stomach ache and I constantly going to an ER for the stomach ache, let's get to the bottom of your stomach ache. Is it something serious, or are you just eating too many pizzas? You know, and often we find that it's diet that causes that issue. And, you know, so can we get to the bottom of it and we make it unnecessary to go to the emergency room, or we make it ineffective to go to the emergency room? We've had some emergency rooms that have told people, don't come back. You've been here 30 times, and every time you come here, there's nothing we can find. Now that, you know, given what Chuck said, they, you know, that's a big decision they have to make because they're taking on a lot of risk. But some of them have finally said that you're taking up space and time that other people who need the service. And emergency rooms are there for emergencies, not for dealing, you know, like I said. But we're moving on to the next slide.
But one question, one comment and question: would the physician really have time to call the client? At the SMI clinics, they're so short-staffed. There's no way they would have time. So how would that work realistically? I would think the pharmacies call doctors when they notice something out of whack, or they notice that someone's left an emergency room and the doc gave them 5 Vicodin or something because they're injured, and all of a sudden they turn that to 500. I know Chuck's had those calls, so they can do it. It's just that
Yeah, they can, although the prescriptions today are primarily done electronically.
Yeah.
It's just creating the backlink to the prescription.
well, they know how to get hold of the doctors.
Oh, they do, except
Yeah.
again, what you're saying is the doctor is often very busy, just like the pharmacist is. But I mean, if they spend the time to restock the medication, there's got to be a minute to click a button and say,
Yeah.
Dr. Goldstein, the prescription you wrote for Lori has not been picked up. I'm restocking. So Dr. Goldstein knows that they're not taking it. So next time they come in, there's some education about it, right?
Or you tell their case manager,
Or
or you
right.
tell the team that, you know, especially if they're on an ACT team, they're not taking
Yeah.
your meds. So,
Right.
so that may be an issue. Low hanging
Right.
fruit.
Right. It is. It would just be a bi-directional flow of information. I don't know how's the timing, Lori? Are we getting out of time?
You have a good 20, 25 minutes. And I mean, people that have to drop, if you want to stay on, if people have more questions, we will have the slides and the whole webinar available after, because we've had several people have to bow out tonight. And I said, don't worry, you know, it's available. So,
Okay, so then the decision analysis that we do is we look at psychiatric, substance abuse, cognitive, biological, medical, social determinants. And a big factor, you know, when we look at psychiatric is we have quite a few people that are abusing substances. So if you're home, and we're going to talk about this later, homeless, abusing substances, you're not involved in treatment at all for your condition. Generally, you're not showing up for appointments. Moving on.
well, they would say that they're self-medicating. They're making their symptoms less for them, right? From a perspective of someone would be doing that. They think they're helping themselves. They wouldn't continue using if it was making them feel worse, right?
That's right, except they're taking, generally the people are taking the drugs that happen to be available today. So they're really poor prescribers. They're either we have to turn them into pharmacists so that they take something that's effective. No one would take meth for a heart problem, but they do. So what I see in the psychiatric area is disorganized thinking, evidence of psychotic symptoms, non-adherence with meds, and substance abuse are main issues that appear. Moving to the next slide. What I'm seeing in cognitive behavioral is residual cognitive impairments, again, health literacy, substance abuse motives, and other motives. So for example, I just came across a guy the other day in we have monthly meetings with each of the teams on high risk people. And I found out one of the guys was, said they have diabetes. So he's getting a prescription for, what are those test strips, which go for about $40. And he's getting repeated prescriptions. And what he does is walk out and sell them so that he can buy drugs that he likes. So somehow we're not even sure he has a diagnosis of diabetes. So a lot of this is detective work. So moving to the next slide. Biological, medical, multiple untreated chronic conditions. Definitely, we see people are not going to specialists, not getting to the bottom of their conditions. We see undiagnosed medical conditions that without going to any PCP or prescriber, it's not being identified. We have a lot of limited or no contact with PCP. We see some people who have multiple specialists who are not talking to each other. And we see some people with multiple medications. Recently, I saw a person who had 36 medications. So I don't think they have to eat dinner. They're taking 36 medications, And, not being a physician or a pharmacist, every one of those has side effects. So if you combine the possible side effects of 36 medications, you're a chemical experiment, and which then leads to something else.
A comment from Janet,
Yeah.
which is right on, is that we need coordination between the doctors, the patients, the OP provider, outpatient providers, trusted caregivers, because as a recipient of crisis calls from families and the one who has a ton of psychiatric cell numbers in our phone, she's the one that's always the navigator, but people should get paid to do it. I agree. I mean, I was talking about a family today. They don't know where to go. They don't know who to call often. And that's what I refer to Andy a lot, but it's
Yeah, Andy's the man. I call Andy. Andy runs the Andy's collision service. That is anybody who runs into the bureaucracy head on. Andy goes and does a repair.
I'm the Andy here.
multi-talented, right?
Yeah, I'm like,
Webinars.
I had a call too yesterday, a patient who the wife knows or thinks he needs AOT, constantly in and out of the hospital, sometimes twice a week, and says he's going to go to his appointments and take his meds once he's discharged. And then he gets out of the hospital and said, the doctor didn't write me a prescription. And what doctor wouldn't do that, right? And then he's going to another clinic to try to get a prescription to hold him over until he can get the doctor to write a prescription. But then you talk to the social worker and it's like, there's more to this story than you know, but I can't share information. And I'm like, you don't need to share information. I already know that there's more to this story. I just need to anyways, and I text the doctors like, why does he need a prescription? I'll write a prescription. So anyway, I'm the whistleblower. I'm telling the doctor, I'm telling the social worker, and the poor wife doesn't know what to do. Anyway, we got him the prescription he wanted. Not that he wanted when he was discharged, but he wanted to be on Prozac or something. So it's like, okay. But, without me, alerting the doctor and the social worker, it's just like he would have just ended up back in the emergency room.
Yeah, that's exactly. There has to be almost a navigator out there. In Arizona, it's Andy. And be nice to Andy because he won an award and I see his dad on the video.
Congratulations, Andy. That's awesome.
Thank you very much.
Anyway, moving on to social factors. We already talked about housing, social, finance, transportation. Moving on. We already talked about Maslow's hierarchy and us up there in the esteem needs, need people to applaud us and build our self-esteem, look down on people who are still working at a physical safety level. And in fact, we would all be down there doing the same damn thing.
But
So
don't you
moving
think,
forward-
yeah, don't you think that now with COVID and everyone in that situation, I know Texas just got a big hit. They're right back from wherever they were on top, and they're back in trying to get warmth, food, water, everything else. People learning new skills, getting toilet paper during the beginning of the, I mean, so all of us can travel up and down, but I think you have to be aware and be empathetic.
Oh, absolutely. It's easy to look down on somebody making decisions like that when you're not in their shoes. So anyway, the challenging conditions that I've discovered in my career across, it's not Arizona. Arizona happens to have a pretty rich system of services. They're not all as readily available, and they're not all, case managers are sometimes just new in their job, and they don't know them all, and it takes time to really be a seasoned case manager. But the challenging conditions that I found are at the center, lack of stable and supportive housing. And I know that ACME has just put out a report, or not ACME, but Morrison Institute just did a research project funded by ACME to study housing and its effects on service utilization. Incredibly great results. Final reports out when, Chuck, in a month and a half, something like that.
I think end of May, I think, but
I think actually the beginning of May, first
Okay.
couple of weeks of May, but we'll see. But that's what it's targeted for at this point.
The results are, in general, very quickly, a person who has stable housing uses 29% less services, high cost services than a person without.
Yes, it is.
And anyway, the study Morrison Institute interviewed providers, families, advocates, people who are being served. And so everybody's saying the same thing. Although just putting a roof over somebody's head, in my experience, is not enough. You have to provide the support needed for them to succeed. There's too many people that get evicted. And there's too many people that, and even some of the evictions are like, well, they went to the hospital for 10 days. I need to fill that bed. That's not appropriate, in my opinion. But that's a battle to be continually fought.
Yeah.
I find substance abuse to be a real significant problem, and I don't think any state, and including Arizona, has enough harm reduction programs. Programs are abstinence only, and many of our people are not going to be abstinent the day they enter those programs, and they're going to be kicked. So we need more harm reduction kind of living environments and programs. Christy Dye, I don't know if she's still on the phone, was an expert in those kinds of programs in her days at the Department of Health. Do you have anything to add to that, Christy? Blythe probably left because I was picking on her.
One thing
Blythe,
that,
No, I'm sorry. I have to drop for a conflict. Great discussion, Dr. Franczak.
But do you agree that we don't have enough harm reduction substance abuse programs in the state?
I mean, I guess my classic response would be that, of course, I'd want to do a network analysis on there. I think that there is definitely a place for harm reduction and a need to really focus on, co-occurring and understanding the needs of addressing behavioral health as well as substance use. And when we think about motivational interviewing and engagement, depending on where folks are at, and making sure that they keep the conversations going.
hey, Blythe, I think some of our psychiatrists that we've had on that spoke of this, from Dr. Minkoff to Dr. Olson to Dr. Darling and many others, all the psychiatrists seem to agree that up to 75% of people with serious mental illness have a co-occurring condition. So it's not like it's a small thing. So I would think that we'd say it shouldn't be the exception. We should expect that, and we should have
Right. Yeah.
we should have tools to manage that, and not just say, oh, you're using, you're out.
Yeah, no, I would agree. And I think that is the part of like thoroughly assessment, you know, as we talked about early, like understanding the story, right? Like what's really going on with somebody. And, you know, creating that relationship where you can have a conversation around it and always asking the question and making sure that, you know, the services are available every time you talk to them, right? Because that's the part of, you know, engaging, and you never know when somebody, particularly if they're struggling with the substance abuse need, might say yes to that. So you never give up.
And
Well,
I
that's
think,
important.
yeah,
Never giving up is important because, but that's unfortunately what abstinence programs typically do, is don't come back until you're sober.
and I
Right.
mean,
And,
yeah,
And
if
so
you
you
look
have to
at,
like have a clinical discussion about the need, right? To say, this is what I'm concerned about, and I'd really like to help get you connected to the right service if that's not here, to be able to provide that support to you versus just saying, you know, best of luck finding it. That goes back to, I think, the navigators, the care coordination. I think those are really essential things when we're talking about transitions in care, or even just, you know, cross coordinating against providers to make sure that, you know, you're all, you know, circling around that person and their loved ones in support.
right.
but I think look at some like Portugal and other places that had tremendous heroin problems, and they kind of turned it on a dime by saying, instead of blaming the addict, they welcomed and said, okay, come in here and use. We'll give you needles. We'll have nurses. You can stay in our rooms. We just want to make sure you don't overdose. And then as they engaged, then they started saying, instead of doing it every day, all day, what if we helped you rebuild a life? They stopped shaming, and they started
Yeah.
helping them get work, re-engage with the community. And I think within a time period, 3 years or something, all of them had stopped using. They went from injecting every day to pills. They said, would you switch to pills? Because then you won't have infection. Then when they were using pills, could you do that less? And pretty soon they dropped on their own because they had built a good life. So it's a whole different way of approaching it.
Yeah, so we need definitely more in that area, in my opinion. And I think Blythe is committed to doing a network analysis, right, Blythe?
Yes, you heard me on that. Yeah, no, I think the co-occurring and, you know, meeting people we're at is very important.
Okay, so moving on so we can, there's high no-show rates. Some no-show rates, some of the literature showing that, you know, something like 20% to 50% of the people fail to return after their first visit. No-show rates across the country can be somewhere between 20 and 40%.
Wow.
Now, let me tell you about the financial viability of an organization that has that kind of issue. One of the things that I've seen is that you are paid for by your encounter value, right? So if you have a 30 or 40% no-show rate, you have no one in the seat to encounter for. So unless you deal with why people aren't showing and do something more aggressive than making a phone call a couple of days ahead and saying, hey, you got an appointment, you're going to continue to have a no-show rate, no one sitting in that seat, and no way to bill for that. So dropouts and no-shows are a big problem. Let's move on so we can get everybody back to their dinner this evening. Another group of people that we're having issues with are people who are aged and need assisted living. The assisted living facilities that we have in Arizona today do not want to deal with individuals who have a mental illness. They are not, and you know, in some ways, thank you, because they're not qualified and they're not set up to do that. But we need more facilities that are. We have young individuals who are first out of their house and don't have housing. and need immediate support. Individuals who ignore and refuse care for life-threatening illnesses. In my career, I've seen people have many of their toes cut off and refusing still to do something about the diabetes. And it's just a matter of time that there's another amputation, and there's nothing they will do about it, no matter how much. And then societal and self-stigma. I learned something from Dr. Chuck Goldstein. I learned many things from him, but one of the things I learned is that why wouldn't someone have stigma or paranoia if during your life everybody was looking at you strangely? It would be very easy to develop some sort of fear or stigma or paranoia about other people, because that's what you're getting back, feedback from your colleagues. So stigma is inevitable until we change it. Okay, so moving on. Here is the protective factors that I found that are for people that are having challenges. One is family. People who have active family members, and God bless them because they've gone through hell in certain conditions in working with their loved ones, who stick in there and continue to advocate and do things like ACME's doing, have a much better course than people who are by themselves or not. And when I talk about family, I mean the person's definition of who that family is at this point in time, who have supportive people, people who have social connections, people who are involved in groups, some of the groups that Andy supports running, or other groups, people that have activation. That means they care about their health. Many of the times, and many of the people were saying, just don't care. But if a person's activated and says, I want to do something about my health problems, that's important. And then health literacy, understanding it is important. Those are protective factors. Moving to the next slide.
And a question was, why do we as supportive families get treated as the enemy oftentimes?
Well, I'm going to go back to Blythe, or did she escape?
She may have escaped. Let me look. She escaped.
She had enough of my inquisitive. Well, I don't know. I think it's, there are many, the vast majority of families are really supportive. There are groups sometimes of family members who are iatrogenic to the situation, but that's so few and far between. I think it's, somehow fear of HIPAA. People need better training in how to involve families in people's care.
You think it would be helpful to try to educate families how to interact with their loved ones' providers?
Yes.
I mean, there's one way to react where they're just going to go, oh, get out of my office. And there's another way to say, I thought you may want to know, this is what I'm seeing. You don't have to tell me what you think, but I think it's important. So maybe kind of from a behavioral functional analyst, or even from a psychologist standpoint and a psychiatrist, what makes people more accepting of the information?
I believe that's absolutely true. And now, because Adalessa is still on, I'm going to call on her to answer that question. Adalessa is a counselor and been a counselor.
Yes, I'm here. I think also, Lori, I really appreciate your comment. We see that a lot. I think that it also has to do on not just teaching the families how to interact with us teams, but I think is for us to see our clients with hope and care and kindness, same, for the family members, because family members have the key to a lot of our questions. And if we don't, interact with them, and if we don't believe in them, like family members and the members that we are serving, then there's a barrier. I think that is also from our perspective, we need to learn to treat people as if they were our own loved ones.
Yes, absolutely. And Andy has come up with some things about how to talk to how to talk to a team. I don't know, Andy, was that done with family members in mind?
I'm gonna put together, I believe I'm gonna put together one that's more specific to family members. What I wrote was for staff, in particular. It was a request that was made to me by then Mark Community Resources staff to write for their staff. And that's what I wrote it for, but it's applicable, and I just got to rewrite it a little bit for families.
Well, Andy, could you, get with Lori and see if we can get family input into this? Because, a family coming in raging at a case manager who's probably, not capable of doing everything, anything immediately about anything, is probably going to be very defensive.
Yeah. The paper addresses all. I mean, what I wrote addresses all that, but just it was written directed towards the staff, but it's applicable for the peers or for the families. I just got to write it so it's a little bit more clear.
Okay, well, please involve some family members if you can. So
Sure.
Moving on to close this out, or getting close to closing it out, here is the Access Whole Person Care Initiative. And unless David Bridge decided to have his dinner, I'd like him to present this. David?
Thank you. Again, I'm only responsible for a small part of it. I'm the housing director for Access. But as you pointed out, there's a definite realization that only a fraction of your overall health and well-being are related to your specific medical care. And that as you brought up in your previous slides, social connection, all these other factors have significant impacts on your health. And so in recognition of that, Access is working on a whole person care strategy to find ways to, again, as you mentioned, where possible, find Medicaid ways to support these efforts. In other places, look to leverage community resources, as you talked about, what we would call community-based organizations, food banks, shelters. Reach out to coordinate people's natural supports. The three kind of key focus of the first round of our initiative, one of them is housing. I'm looking for ways to expand housing resources for members. And that, as you brought up, that's not just trying to find housing placements and vouchers, which is complex, but also looking at those supportive services and how we integrate services into the housing. Another initiative deals with social isolation for our Altex members. Again, as you pointed out, social isolation is one of the fastest ways for people to be compensated and have troubles. So trying to create more social connection for our Altex members. And then transportation, trying to find non-emergency transportation resources that could be used to wrap around people to get them not just to medical appointments and crisis appointments, but just again, as we've seen with COVID, right, getting to grocery stores, getting to food and other resources. So again, I'm not the expert. At a future meeting, if you'd like us to coordinate somebody who's kind of leading this effort, I'd be more than happy to connect you with them. But that's just a quick summary of kind of some of what we're working on right now.
And the initiative began in November, so it's really just getting launched. And I see this as being a major advancement. And I don't think David just knows about housing. I think he sees the whole clue of all these things that fit together to make a person successful and happy. Right?
Yeah.
I do, but they only let me play with housing. So.
All right. Okay. So moving on, I think we're almost done, Lori.
Okay. And then we have some comments and questions about the discussions between.
Let's forget this one because we talked about it overall. The other thing I want to recommend it to all family members that are here. Dr. Setterer, who used to be in charge of the New York mental health system, wrote a book about the Family Guide to Mental Health Care. It is advice on helping your loved one from a medical director of the largest state mental health system program. He's a really smart guy and a really sensitive and knowing person. So I brought in a few quotes here that he had in the next slide. I highly recommend this book. It says from the beginning, mental illness doesn't stop at the person who's ill. It places great demands on families, stoking tensions and often pitting parents against each other. It sucks parents, siblings, and other families into its maelstrom. Mental illness is the visitor nobody wants. Moving to the next slide. These are just some of his insights. Mental illness can improve and people can build satisfying lives, just like other people with physical illness. But both mental illness and physical illness needed to be treated as early as possible. When medications and therapy is combined with an informed and supportive family, each element builds on each other and optimizes the chances for recovery. He couldn't, I'm not even going to read the last, you go buy the book. You can probably get it on Amazon. Of course, you'll leave a digital
Kindle
print, or yeah, and they'll be selling you other books. But and then, you know, the systems aren't set up to do everything. So could you imagine a person with heart disease ever tolerating similar odds? A 20% chance that you'll get what you need? No. So I really respect and support what ACME has been doing to bring the family voice to Arizona and advocating for not, you know, Arizona has a lot of things. Getting them to work together nicely is, you know, an issue that needs to be worked on. So
we had a lot of comments about families being heard, physicians being open, physicians, you know, I can tell you that with some of the clinicians we've dealt with and some that have done webinars, and there's some up on our site from Dr. Darling, and I'm spacing on another one about they were talking about psychotic disorders and the difference between catching it early and catching it late. And it's almost like totally different diseases, right? And both of them, one's an ACT team psychiatrist for people with SMI, and the other one is first episode. So they see the absolute differences. Both of them, and I know I've heard from my husband and a lot of our friends that people interested in really getting to the bottom of something and treating a person, they'll take all the input they can. And HIPAA goes out the window. When there's a crisis or an emergency, Chuck said, we don't care. You know, someone comes in unconscious and we have no idea. We're grabbing all of them and asking what's going on. We're going through their wallet and calling all of their contacts. So I think it just, you have to try to get your point across. And I know it's not trying to make someone look bad. Our son was a horrible historian. One, sometimes he was in a psychotic state. Two, he didn't want to appear when he was not in a psychotic state, admitting to all the behaviors that he had done. And he'd say to me, well, I bring up the past. And I'd say, well, the past 24 hours is important. You know, I mean, you know, I know I'm not trying to make you feel bad. You can leave the room, but, you know, talk to the police, so I think that it's important to get a whole perspective. And they can dismiss what you say, but they can also validate it, you know, especially if the person's been hospitalized 9 times in a year. You know, when they say they're doing fine, not so much.
Yeah, you're right. I think we've got to do, if anything, from this webinar is that importance of family involvement and having families being able to communicate to the team in a way that is respectful. I think Christy Dye, what is the quote that we had for some organization we were working for? Do you remember it?
A quote?
Yeah, I think it's coming back to me. To do good treatment is bringing in the wisdom.
Oh,
Yeah.
yeah.
Go.
yeah.
Do you remember it?
The wisdom of professionals. Well, it was the wisdom of family members and others that loved them,
With the professional expertise. That
coupled
provide,
with professional expertise and evidence-based practice was in there somehow too. Yeah.
so
Yeah. That was a PIR saying.
the original motto was definitely get particularly families that are involved. And again, I have to mention that we found some families that we probably would not involve because of uh, all kinds of reasons. But for example, family members that are using drugs that we send a person back to the home in. Definitely, we don't want them involved in the care. We need to get them out of there. But it was bringing in the wisdom of families with the expertise of professionals using evidence-based care. So that's the end of my slides.
And I think from a different perspective, no matter what realm of life you dip your toe in, I know that as an engineer, if you think you know it all in a lab or a fab, you're going down. I used to walk around and I try to do the processes that I wrote, and I'm like, oh, someone must have hit me in the head. Why don't you guys tell me? And they got to know me, and they would tell me. I said, what are you seeing? What do you think? Because people that are there every day, digging the ditches, doing the job, the nurses right there with them, they're the ones that are going to see minute changes and are going to be able to tell you those things. So I think you're missing a lot in any area of life if you don't talk to the people closest to the issue, the problem, the process.
That's right. You've got to be, the closer you are to the job or the issue, the more you're seeing, the more you're taking in. You cannot make decisions from 6,000 feet up.
You can make decisions, bad decisions, right?
Yeah.
Okay,
So,
well, thank you, Dr. Mike, and I know we ran over, and thanks for those that have stayed in. We'll get this up and loaded on the site. Again, if you want a certificate of attendance, please ask. I know we're working on getting CE, continuing education. I have to talk to Shar and see where we are with that. I'm coming back to where you can send something.
And I, like everybody else who I picked on tonight, thank you. You'll know better that if I'm doing a webinar, I ain't going to be doing all the talking.
Well, thank you again. And for those that don't know, Janet Hayes, who was on, does wonderful, wonderful webinars, NOLA, Healing Hands, and she usually has great speakers.
Laura, it's Healing Minds NOLA, and yeah, and you can go to our website under the home tab and see our video archives. It's a .org, healingmindsnola.org.
Yes. Okay, well, thank you, and we look forward to the next one. I think we're going to be doing a release on the Morrison Institute study, which is what is the true cost of not treating serious mental illness, looking at the police encounters, the hospitalizations, the lack of housing, and we have a teaser out, a 2-pager for the legislature, but we'll have the full report and a video presentation as well. But thank you guys. Have a wonderful night. Thanks for spending time with us.
Good night.
Thank you.